Hello and welcome to this introduction to ultrasound. My name is Giuliano de Portu. I'm one of the emergency medicine physicians here at the University of Florida. I'm also the director of ultrasound in undergraduate medical education, so that means you guys. I have nothing to disclose. I take no money from any of these companies. The objectives for this introduction is gonna be to discuss the origins of ultrasound. Why we actually have ultrasound in medical education, discuss some terminology and some common artifacts that we encounter in ultrasound, and we'll go through an example of clinical use. Welcome to the University of Florida. If you're not a Gator, you are a Gator now. And we'll start to talk about this gentleman, René Laennec. He's famous for this invention in 1816. So for about 200 years now, we've used variations of the stethoscope. Everybody thought that he was crazy initially, but I guess he wasn't. So here's a painting of Mr. René Laennec listening over the back of this patient, auscultating the lungs. But there's a lot of momentum with point-of-care ultrasound and medical education. And there's an article that basically said, point-of-care ultrasound, stop listening and look. And I don't think we're going to throw away our stethoscopes yet, but definitely a lot of good things with ultrasound. And ultrasound started because of this worldwide event, or important event, and there was the Titanic. We saw the movie. She sank in 1912. Actually, April 15th, 1912, like tax day. And so they wanted to find icebergs. They wanted to create a device that can find icebergs. So geolocation was developed, and the first sonar, sound navigation and ranging, was used in 1914. So the submarines were using sonar to look for objects in the water. So the military was really interested in the finding of objects in the water. So a lot of research initially came from submarines. And this is probably the first clinical ultrasound. It was used at a naval base in Maryland, I think, by Dr. Ludwig. In the 40s, the initial research was classified, but he was looking for gallstones and foreign bodies in tissue. And we have machines in the early days that look like that, pretty much like coming out of a car machine shop. And obviously, as technology advanced, things got a little bit better. But the initial imaging that we got from ultrasounds is basically, we're plotting distance to objects. So you see it's kind of rudimentary, not really clinically interesting. But, this is the beginning of ultrasound. And in the 60s, Life magazine put out this article on, the control of life and how to look into the body. You see this lady here. There's a big bag of fluids with an ultrasound probe in there, and there's what is the fetal head there. So a lot of, obviously, the initial ultrasounds were done for pregnancies probably. And there's again this bag of water over here, from the days of submarines and the sea, and that probe is there. So the whole bag of water was actually touching the patient. And again, this is a fetal head. This gentleman here is sitting in a big pool of water. Doesn't look very happy to be sitting there with a bunch of electricity and cables coming in and out, but I guess he was doing it, for the improvement of science. So good for him and for us. But ultrasounds obviously have gotten smaller. This is a device that you can actually put in your white coat. They have ultrasound machines that are you can hook it up to your tablet or phone. And this is kind of a new one that's kind of coming out. It's kind of a finger probe there. So you can actually use your finger as a probe, and you can here they're looking at the wrist of a patient. This was, again, developed by the military. You could put this on your finger and actually slide your hands under a soldier's armor and look and do, assess for any injuries. So that's pretty interesting. We use it in pre-hospital care. There's some folks there in a helicopter doing an ultrasound on a patient. And, guess what? In the space station, they don't have room, or they don't want to carry extra weight, so they can't put in a CT or an MRI up there. So what do the astronauts do? Well, they're trained in doing ultrasound. They look at a lot of parts of the anatomy that they want to check. If you think about it, you don't want to bring an astronaut down, do what's called a deorbit, unless it's truly necessary. So they examine themselves, and you don't want to bring them back. If you think about it, it's a $400 million ambulance ride if you were to bring somebody down. So the study of anatomy basically has being transformed from this traditional painting by Rembrandt to what we kind of now do nowadays, which is help you guys understand anatomy with ultrasound. And again, I love dissections. I was an anatomy TA, and those are irreplaceable experiences in medical school. So this is just like extra things that we were giving you guys. So ultrasound, we need to talk about bats, and that is the bat house here at UF. And we talk about bats because there were early experiments in the 1800s done by a gentleman called Spallanzani, an Italian guy who blindfolded bats, and he figured that they could navigate if they're blindfolded, but they bumped against each other or against obstacles if their ears are covered. Again, I don't know how he blindfolded bats, but he managed to do that. And in the 1940s, what was called Spallanzani's bat problem was kind of figured out at Harvard, and they figured that bats would emit sound waves around 100,000 hertz. So other animals that use geolocation, dolphins, concepts of piezoelectricity. Pierre Curie found that some types of crystals reacted with an electrical potential when mechanical stress was introduced. So that was important because that's the basis of how our transducer probes work. And here at the mighty Shanth, this is the adult ER on a cloudy day. We see about, we're a level 1 trauma center. We see more than 100,000 visits per year, and a lot of those are trauma patients. And being a level 1 means that we have all the subspecialties on board. And this is one of our trauma bays, and for those photography aficionados, that's a fisheye lens. An 8 millimeter gives you 180 degrees of view. Looks like a fisheye. They call it fisheye. But in the trauma base, obviously, we have ultrasound machines because we use them all the time. This is one during a trauma code, trauma alert. Everybody's suited up for action there, and you can see in the left portion of your screen the ultrasound machine. And this all started here in 2013 when we had our first, ultrasound course. This our emergency medicine faculty up here. That's Dr. Rohit Patel, myself, Dr. Connor Nichols, and Ika Flock. And these are just the students. These guys are now in residency, so a couple of years have gone by. And, we did a little pilot study that basically showed that basically no one had a previous experience with ultrasound, but everybody was very, very convinced that the hands-on helped them in anatomy of the cardiac anatomy, cardiac physiology. That was our first module that we did, and that 100% of the students agreed and strongly agreed that they wanted more ultrasound. So that's why we're still here today. So there's plenty of evidence out there that has looked at ultrasound in medical education, from California, Ohio State, Dr. David Boehner. He's like the godfather of ultrasound, really nice guy. And, Dr. Hubman and University of South Carolina. Again, he was also one of the founding fathers of ultrasound in medical education. So a lot of stuff going on. John Christian Fox leading this article. He's from UC Irvine, California. Also a really nice guy. And, ultrasound and medical education, pretty cool. We had a competition in New York, and we took a team here from UF, the Sonogators, I think. We couldn't come up with a better name. But Matthew Earl, Rachel Holm, and Annie Carpenter, they're currently third years, and we had a great time over there. Here you see them scanning, going through multiple stations. Really, really hardcore competition there. And best ultrasonologist was awarded to Matthew Earl from the class of 2018, so that's pretty awesome. But you might be thinking, I don't really like ultrasound. I'm not going to use it. Still, I really think I don't need it. So when you come across cardiology, physio, and you get this chart, which is a pretty easy chart. As you can see, there's a pressure and a volume, and you have the electrocardiogram, and you have the heart sounds, and then you have pressure loops, and as the valves open, you lose pressure, right? Really simple chart, right? So basically, we're just trying to scare you. You will get this. You're gonna be able to get these. And we would just want to use ultrasound to try to help you understand all these concepts of anatomy and physiology. If you look at the heart, obviously you'll do dissections, but we want to show you, how the heart, how blood flows through the heart there. And red and blue is, not arterial or venous. It just indicates direction of flow. But here at UF, what we've been trying to do for several years is to continue to have a longitudinal curriculum through the 4 years of medical school, and we've had great support from the dean, so that's great. And interesting literature out there just got published when there's a consensus among ultrasound directors regarding the milestones that every medical student should know regardless of specialty. Really interesting. If you think about it, you are going to be exposed to ultrasound one way or the other because you're ordering a test, because you're trying to interpret a test. So interesting stuff there. I was lucky to be a contributing author on this paper, so pretty cool. So when we talk about ultrasounds, we have to talk about physics, and when you hear the word physics, that's kind of what I look like when I hear the word physics. But we know briefly we have to describe that sound waves are mechanical because they carry energy, and you have what looks like a typical cycle of a wave there. We have amplitude and time, and basically for the sci-fi fans out there, and I'm a hardcore sci-fi fan, the slogan for this movie was, "In space, no one can hear you scream." And it's completely true. Sound is a mechanical wave. It cannot travel in vacuum. So it needs a medium, just like air, water, to propagate. That concept is called medium disturbance. Okay? And when you look at waves, they have obviously different wavelengths and higher or lower frequencies. But I can tell you that, in dry air, the speed of sound is about 343.2 meters per second. It travels about 4.3 times fast in water. And again, water is a denser medium because it's, we talked about that medium disturbance. If you think about it, water being a liquid is denser than air, which is a gas, obviously. And in a way, molecules are packed tighter in water than air. So, it just travels fast. And this is just, I figured I'd throw in a really cool picture of an F-18, going supersonic. There's condensation there of air. You see that cone. If you think about it, the plane is supersonic, traveling faster than sound. That's a little red dot. And the sound waves are propagating behind the airplane. And that creates a cone of sound. And basically the summation of all those waves is what you actually hear. And that sonic boom is not actually when they break the sound barrier. They don't break anything. But it's just when that cone, that summation of those waves, that cone hits your ear. That's when you hear the boom. So, sorry. Sound waves are measured in hertz, and that's a standard unit of measurement that measures the frequency. And it's measured in cycles per second. 1 hertz equals one cycle. And hertz, it's commonly used to measure wave frequencies such as sound waves, light waves, radio waves. And you have hertz, kilohertz, which are thousands of hertz, and megahertz, which are millions of hertz. So your ear, will perceive audible sound within that range of 20 hertz to 20,000 hertz. So unless you have dog genes in you or you're part wolf, you're not going to hear anything greater than 20,000 hertz. An important clinical ultrasound, the one that we use, all those probes that we are going to be putting on patients and on each other, very important clinical ultrasound ranges in the millions of hertz or the megahertz. And those probes, when you're putting them on a patient, they function via a thing called the pulse echo principle. So basically, we have a probe over here, we have a sender, and it starts to send waves, to the right, those red lines. And basically, when they hit an object, the probe kind of listens for that reflection, that wave, or an echo, basically. So going this way, it hits an object, and that object is at a distance r, and it listens to those echoes, right? And those returning echoes are plotted with an intensity of the reflection and the depth of that echo, of that structure. And when we talk about ultrasound, we have to talk about like very basic terms, because otherwise this is just, it looks like 50 shades of grayscale, right? So when we talk about structures in relation, we have to talk to those structures in relation to each other. And you're going to hear the terms hypo in medicine, hypertension, hypotension, anechoic, anisocoria. Those are medical terms, and those prefix means different things. So hyper means high, like high blood pressure. So if we look at the structure here in relation to the surrounding tissues, those have like brighter echoes, right? So we call it hyperechoic, kind of bright there. If we look at this one here in relation to the surrounding structures, it has hypo, lower echoes, so hypoechoic. Okay, and the last one, a very important one, is you're having echoes all around, but this one doesn't have an echo. It's anechoic, and mean without, and blood vessels look like that basically. So if you compare the three, kind of a very, very interesting slide, important slide, that you actually compare all those three echoes, or what we describe as the echogenicity of an image. And basically, tissues in the body respond with different echogenicities. So bones, for example, are calcifications, have the highest amplitude. They're really bright, they're really hyperechoic. And as you go down, you have fascia, diaphragm, soft tissues, fluid, blood, urine. So they have the lowest amplitude. They come out like basically anechoic. And some artifacts are created because of physics of ultrasound, and they're really important because the presence of those artifacts or the absence of those artifacts allow us to, diagnose pathology. And a very common, or one of the most common artifacts, is shadowing artifact. And it occurs because your probe is always going to be, the superior portion of your screen is going to be where your probe is touching the body. So this is a gallbladder, I can tell you that. And the waves are coming down, and they're hitting all the structures, and they're creating an image because all the waves are coming back. So what happens is when you encounter a highly reflective structure or surface, the waves kind of like bounce back, and there's not a lot of energy to continue, so it creates a shadow. Okay, so it creates kind of a clean shadow, and it's very, very common to see that shadowing. That's a gallstone in the gallbladder. Another one is what we call edge shadows, and then because there's a direction, again, probe is up here, sound waves are coming down. Every time there's a cystic structure, with a curve, basically that sound beam crosses a boundary and reaches that curved structure. The sound waves are scattered and refracted, so they just kind of like, instead of going down, they kind of like go sideways. And they also create that there's that energy loss and the formation of a shadow because of it's a cystic structure. Again, common to see. This is a globe, an eye. So this is a cornea, this is a lens, and this is called acoustic enhancement. This is also very important because you're having waves come down, with echoes. What happens here? You have a structure that it's not a lot of resistance in a way. It's called less attenuation. So what happens is the wave comes down, it doesn't meet like any resistance, so it has like a lot of energy. When it hits that posterior part of that cystic structure, it looks really enhanced. So there's more energy left in the beam, and that's called posterior acoustic enhancement. We have to keep in mind that when we're measuring, for example, the gallbladder, if we were to measure the posterior portion of the gallbladder, we would have kind of a false positive. We would think it's enlarged, but it's not. It's because of that, artifact. So gas or air, obviously sound travels through air, but when we have air, like in the lungs or in the bowel, for example, it creates an artifact, and it just blocks our view. This we have this is probably the liver with a blood vessel, mainly probably the aorta. And what happens here is that you probably have a transverse colon creating that air artifact, and it just blocks our view. So air is not our friend. This is called reverberation, and this is a bladder, and this occurs when the sound waves hit a structure that's really highly reflective. It starts to create like equidistant lines. You see there's a line here, and there's a line there, and this is lung tissue. So the pleural line is here, and you're going to start to have equidistant lines from that first line, and that's called a reverberation artifact. And that's, again, also normal. Mirror artifact. This happens when you have two structures. This is two structures. I'm going to tell you that's the liver and the kidney. And then you have the diaphragm right there. And they appear when you're on both sides of a strong reflector. Basically, the sound waves are coming down. It hits a strong reflector, and you have multiple reflections back and forth along that line. So the machine thinks that there's liver on both sides, when obviously you have liver in your abdomen, you don't have liver in your chest. But it's a common known artifact to have that mirror. The loss of mirroring would indicate pathology, and you'll learn about that a little bit down the line. This is a drawing courtesy of my dad, who's a retired architect, and he can only talk if he has a piece of paper in his hand. God bless him. He made this picture, and basically he's telling us that when you're measuring a cylinder or a blood vessel, if you're not measuring in the right smack the center, you're going to have a problem. Why? Because it's going to change the actual size of your image, and that is called cylinder tangent error. And why is that important? Where you measure? Well, because if you put your probe, and you measure here, you're gonna, measure along that axis. You're gonna have basically a diameter there. If you measure down the middle, you're gonna have a greater size. And why is that important? You think about it, we're trying to measure the aorta. We're trying to figure out if that patient has a dilatation of the aorta or what's called an aneurysm. It's really important for me to know if he has an aneurysm or not. I don't want to send him home thinking, no, it looks great, go home, when it's actually bigger because I'm measuring in the wrong spot. So cylinder tangent error. This is some of the folks in the emergency department, asking for antibiotics, but we don't really do that, but it's a virus, So setting in planes. The transducers, they all have a little dot or thing on the side. It's called the indicator, and that allows us to put our probe, and actually when we look at the image on the screen, we kind of know it orients our anatomy, right? And this is some of the most difficult things that we do, and students also get confused with which way is up, basically, but you'll get the hang of it as the more you do ultrasound. But basically, we scan in 3 planes, just like the basic anatomical planes: sagittal, transverse, and coronal. And these are just images. This is the probe. This is the indicator pointing towards the head, and we're measuring the sagittal plane. And this is kind of like taking a slice of the anatomy, right, and pulling it on your screen. And as a reminder, that slice of anatomy is about 3 or 4 millimeters thick. It's not thicker than that, so it's a very thin slice. So our indicator is pointing towards the head. Here's an indicator pointing towards the head. So we know that the head is over here, the feet are over there, and you're anterior to posterior, okay? If we switch our probe around, what we did here, we went from the sagittal position, we rotated it counterclockwise, so now our indicator is to the right of the patient, and we're scanning in the transverse plane. So now we know that this is our indicator pointing towards the right of the patient, so this is going to be the right, the left, anterior and posterior. This is kind of like if you're slicing in a way your patient like loaves of bread, kind of like a CAT scan. So you're basically looking kind of from the feet up. And we can also do coronal slice, and again, indicator is pointing upwards. So now you're looking on the coronal plane. So the superior portion of your screen is always where my transducer is touching the skin. So if we're looking from this side, this is going to be, the head is going to be, indicators upward, so the head is up here and the feet are down here. So are we touching on this side? So this is going to be what? It's going to be lateral to medial. And again, you'll get these concepts as you continue to learn ultrasound. And we also need to talk about what's called the functionality of controls of an instrument as relevant to their application. That's called knobology. And if you're going to take one thing out of this lecture, and I hope you do take more than one thing, is that this is where you turn the machine on. And obviously, you have other things. You can zoom, you have the depth of your image, you have different modes, M mode, Doppler, color, and 2D. That's kind of your escape key in your computer. It resets back to the main screen. And you have different transducers or probe. This is a high frequency linear, kind of flat looking. You see that it's 6 to 13 megahertz. This is called a phased array, and this is the abdominal probe. And you see that all the probes, regardless of the probes, they all have what we call the footprint, and that's actually where the magic happens, where the ultrasound is actually sending the signal. Please be gentle, because they are worth more than my car. Each probe is about $15,000, and the machine is about 40 grand. So yeah, please handle with care. We talk about the modes, and A stands for amplitude. That's kind of the old looking picture that we saw when you have the little spikes. And then we have B mode, M mode, and D for Doppler. So B mode is basically brightness. That's kind of like every picture that you're looking at when you're doing ultrasound. And then you have M mode. M mode stands for motion, and it's kind of really cool because you hit M mode and then you get a line, and you can move that line through your screen, and basically you choose an area of the anatomy that you want to look. So the machine, once you pick that area of the anatomy, it'll give you that area of the anatomy plotted in time. So here we're looking at the mitral valve of the heart, and it's actually showing the motion of the mitral valve as it closes and opens. So pretty cool stuff. Then you have Doppler, and those are obviously blood vessels, and you have flow. And again, that doesn't indicate arterious or venous. It just indicates direction of flow. We'll talk about that later at some other time. This is a bladder, and these are urethral jets. That's actual urine going into your bladder. And we look at those when we're trying to see if a patient has a kidney stone. You can control the depth of your image. If you look here on the right lower corner, you have you have depth in centimeters, 20 centimeters. That's probably too deep, so you can just regulate the depth and make it adequate. That's obviously really too deep. 35 too deep. That's 16 adequate. And for those of us who remember black and white TV, there's a thing called gain, and they all had that. And gain, and you can see it here on the left side of this machine. Basically, it controls the overall strength of those returning echoes. So basically, it's either too bright or too dark. So this is what's called overgained, and that's kind of adequate gain. Okay. So a little bit of art history here. This is a drawing by Leonardo da Vinci from the 15th century. It's called the Vitruvian Man, and it was because of an Roman architect, that basically said that the perfect human proportions, if you took a man's the width of his arms, they should be equal to his height, basically creating a perfect square. And if you took the belly button, the umbilicus, as the center, and you kind of did like a jumping jack there, you could create a perfect circle. So those were like kind of the the perfect proportions of a man. And I put that there because I think it's a cool drawing, and I'm not sure if you knew what it meant. Hopefully you've seen it before. So we scan, like I said, we scan from, eyeballs to ankles in the ER. And one of the clinical things that we do with ultrasound, which I think is pretty cool, we had this patient, she was a young female with a cough. She got this x-ray, and I'm not going to teach you how to read x-rays, but once you start reading radiology images, you're going to look at a bunch of normals, and you're going to see like, whoa, this is something weird. I don't know what it is, but it's not normal. If you compare it to the other side, you see that there's, something going on there. Could it be a pneumonia? It could be a pneumonia. The problem with this patient is that pneumonias are usually not like in the periphery, and this looked a little bit wedge-shaped or, triangular in nature. And sometimes that occurs when you have a pulmonary embolism or a blood clot in your lungs, or you can have a pulmonary infarct, basically. And then it, the way the blood flow of the lungs occurs, it gives that, that wedge-shaped triangular appearance. So my question was, does this girl have a pneumonia or does she have a pulmonary embolism? And different modalities of imaging occur in medicine, right? And ultrasound is great, but it's not the one and only imaging modality. You've had probably lectures, and you might need other imaging modalities. So does she need, the only way that I can truly diagnose a pulmonary embolism is to do a CAT scan of her chest with IV contrast. And that's a lot of radiation for like a 19-year-old, because there's always a risk of, cancer down the line. So what did I do? I put my ultrasound probe there, and this is what it looked like. This is right upper quadrant. This is the liver and the kidney. Remember how we had that artifact called mirroring? So we used to have the pleural line, and then we had liver on both sides. But what's wrong here? We lost the mirror, and now we have this area that's anechoic, right? It has no echoes. It's dark. So that indicates that there's fluid there, and there's something here moving. That's obviously her lung. So she has a pleural effusion. And not only that, as I looked closely, I looked at the lung tissue, and I saw that it had all these, are these hyperechoic? They are. They're brighter, right? So we call them hyperechoic. So foci there that basically it looks like there's consolidation there in the lung. So in the setting of a cough, a fever, this ultrasound, I was able to diagnose it and say, like, no, you have a right lower limb pneumonia. I'm not going to scan you. Obviously, you talked to the patient, and she agreed, and she got antibiotics, and she was admitted. And this is just a publication that discusses, findings of ultrasound and pneumonia. And we talked about those air bronchograms, and they also call it hepatization of lung tissue. So it kind of looks like liver. So this is kind of my, a touchy-feely moment here. This is, your medical building, College of Medicine. It's a brand new, awesome building. And this is your class picture that I borrowed from Facebook, I believe. Like, guys are looking awesome there. And you're obviously, hitting up social media, which is cool. And this is a picture of, I don't know if you know who this guy is. This is Patch Adams. He's the doctor that was in a movie done by Robin Williams. And basically, this is a picture of Robin Williams and Patch Adams. I took the previous picture. I used to be a photojournalist for many years before going to med school, so that's another story. But my two seconds of advice here is like, learn, but also have fun. Enjoy this process of medical school. It's awesome. I want to tell you to listen to your patients. Connect with them. They will give you the story and of their disease. If you learn how to listen, you will help them. Learn to balance life and class. You have tools here at UF, CLG groups, support. Use those tools. We want you to succeed. We want you to walk there and all of you become doctors. But don't wait until you're you're drowning, you're overwhelmed. Just reach out and we will help you. You will learn from your classmates, your professors. Learn from everybody, nurses, techs, the gentleman or the lady who cleans the floor, can teach you compassion, humility, be humble. Medicine is a very humbling, career, especially emergency medicine. Just when you think that you know things, something changes and you're here, you will learn every day. The day you think you're not learning anymore, that's a problem. So carpe diem or seize the day. Robin Williams, he unfortunately passed away 2 years ago, but funny guy. And Patch Adams, also crazy guy. So this is a website that you were gonna go for asynchronous learning tools, videos before you come into your labs. You can check those out. If you are more of a ultrasound aficionado and you want to take it a step further, we also have these videos a little bit more in depth of different subjects there. You can follow me on Twitter if you want. Social media, mainly medical, and cool things that I would put there. So basically, in summary, ultrasound medical education is helpful in your learning of anatomy and physiology. We measured ultrasound in hertz. It will be a part of your medical career regardless of your specialty. And, the knowledge of artifacts will help you to guide your diagnosis, basically. So that's kind of it. This is my son. He's 4 years and 7 months, going into 40 years. He's doing awesome. And that's my Twitter handle and my Instagram. And if you have any questions, just shoot me an email. All right. Thank you. And we'll see you soon.